No. Okay. Good afternoon. I'm Karen Anderson. I am the director of the Roundtable on the Promotion of Health Equity under the Board on Population Health and Public Health Practice at the National Academies of Sciences, Engineering, and Medicine. I want to welcome all of you to today's webinar on Pursuing Data on COVID-19, the Health Inequity Multiplier. We are in the midst of an unprecedented public health crisis, the COVID-19 pandemic. States and communities have begun reporting that the pandemic is disproportionately affecting people of color, but the available data on the past pandemic is not robust enough to support an appropriate response that promotes health equity in our communities. The Roundtable on the Promotion of Health Equity is developing a series of short webinars to focus on critical issues related to COVID-19 and health equity. This webinar is the first in the series. Also, this webinar is being recorded and the archived video will be available at the link that you will see on the last slide. I would now like to introduce the moderator of this webinar. We are very fortunate to have Dr. Winston Wong, Medical Director of Community Benefit and Director of Disparities Improvement and Quality Initiatives at Kaiser Permanente. In this role, he is responsible for developing and cultivating partnerships with communities and agencies to advance population management and evidence-based medicine, with a particular emphasis on safety net providers and the elimination of health disparities. His background includes leadership roles in community health, government, and health plan delivery. And Dr. Wong serves as the chair of the Roundtable on the Promotion of Health Equity. I turn now to Dr. Wong, who will provide some opening remarks and introduce our speakers.
Well, thank you, Karen, and thank you everybody for joining us in this webinar of this profoundly important topic. And I want to thank you, my fellow Roundtable members, a couple who you'll meet in a few minutes, for organizing this webinar and its critical feature. Just by way of short introduction, I want to give you a little sense of what the Roundtable on Health Equity does at the National Academy of Medicine. We were established roughly 10 years ago, and we really exist to surface critical questions around health equity and disparities that confront our nation and our country. We normally do this by having convenings in various locations across the country, because we like to bring forward voices that come from different parts of our country, different neighborhoods and communities, and we like to highlight a particular issue or insight that is relevant to the issue of health equity. So, for example, in the last year or so, we've had convenings in places as varied as Philadelphia, when we focused on the issues of incarceration and health equity, in Oakland, and looking as immigration as a social determinant of health. We also had a session around the impact of California wildfires on vulnerable populations. And most recently, we were in Arizona to look at the issues of juvenile justice and health equity. So we invite you to follow us throughout the year. Hopefully we will be on the road again, but this particular event enabled us to put together this webinar in a relatively short time. I want to make sure that we acknowledge how much pain is occurring throughout our communities with regards to COVID-19. I know for us who are sheltering at home or are caring at the front lines, it's an extremely stressful situation. At the same time, we've already lost 50,000 lives more lives than we lost during the entirety of the involvement in the Vietnam War from the United States perspective. So the loss of life and the loss of life across vulnerable populations is particularly profound. And it's important for us to recognize that loss, as well as to express our deepest appreciation to all those individuals who are at the front lines caring for our communities and our loved ones. But with regard to the issue of this particular webinar, I think it is very clear that we're starting to see trends with regards to the disproportionate burden of disease, mortality, morbidity among communities of color, and certainly particularly maybe other populations we haven't thought about in terms of nursing home residents, the impact upon folks that are disabled, the impact in Native communities. These are critical questions that are not only being reviewed, but exposed as we get deeper into the pandemic. And given that, this particular webinar attempts to explore what are all the complicated issues for us to understand data more specifically, and to enable us to really harness this data to be more impactful as we address health equity. For example, we're seeing data that suggests that in places like Louisiana, and we'll hear from Dr. Gee, the disproportionate burden among African Americans in the Black community is 2 to 3 times higher than their proportionality in Louisiana as far as the overall population. In Washington State, we are seeing that though Pacific Islanders, Native Hawaiians only make up 0.7% of the total state population, they're making up 1.7% of the reported deaths. Now, I underscore reported because we have incomplete data. And our webinar today will attempt to answer some of those questions, or at least surface some of the critical questions that are in front of us. So with these, all of this in mind, I'd just like to outline again the objectives for this webinar. One is to provide an overview of COVID-19 demographic data and what we currently know. 2, share any substantive, validated, disaggregated data that describe potential areas of disparity, including race, gender, geography, and socioeconomic status, and the implications of limited data on our response in our communities. And we'll be talking a lot about the limitations of our data, as well as the limitations of how we gather data. So along that line, I just want to now introduce our 3 esteemed panelists for today. And they will go successively. I won't interrupt each speaker at the end to introduce the next speaker. I'll just introduce them right now. Dr. Lawrence Brown is our first speaker. He is the Director of County Health Rankings and Roadmaps and visiting associate professor at the School of Medicine and Public Health at the University of Wisconsin Population Health Institute. The County Health Rankings and Roadmaps program provides data, evidence, guidance, and examples to build awareness of the multiple factors that influence health and support community leaders working to improve health and increase health equity. Previously, Dr. Brown was an associate professor in the School of Community Health and Policy at Morgan State University. His research examined the impact of historical trauma on community health, and Dr. Brown is a proud grandson of Mississippi Delta sharecroppers and preachers. After Dr. Brown speaks, we'll hear from Dr. Rebecca Gee. She is an obstetrician gynecologist and Chief Executive Officer of Healthcare Services for Louisiana State University Health. She is the former Secretary of the Louisiana Department of Health, the state's largest agency with a budget of $14 billion. Her oversight responsibilities include public health and other direct services, emergency preparedness, and the Medicaid program. Under Dr. Gee's leadership, over 500,000 Louisianans became newly insured under Louisiana's Medicaid expansion. And for the first time, many started receiving much needed primary and preventive care. Her Medicaid expansion work also resulted in the launch of a dashboard to measure access to healthcare services, which has become a national model used in other states. She has been a national leader in tackling pharmaceutical pricing, including spearheading an innovative effort to eliminate hepatitis C in Louisiana by negotiating with manufacturers on a subscription model for drug access. Dr. Gee has a long history of work as a scientist, healthcare provider, and advocate. And then our third panelist will be Dr. Stephen Thomas. Dr. Thomas is a professor of health policy and management and director of the Maryland Center for Health Equity at the University of Maryland School of Public Health. He also serves as a commissioner of the Maryland Commission on Healthcare. Dr. Thomas is considered one of the nation's leading scholars in the effort to eliminate racial and ethnic health disparities. Dr. Thomas has applied his expertise to address a variety of conditions from which minorities generally face far poorer outcomes, including cardiovascular disease, diabetes, obesity, and HIV/AIDS. Dr. Thomas's work has focused on understanding how social context shapes attitudes and behaviors of underserved, poorly served, and never served segments of our society toward participation in health promotion and disease prevention activities. So we want to thank you, Dr. Thomas, Dr. Gee, and Dr. Brown for being our panelists today. Finally, I will say that at the end of the three panel discussions, we'll have a couple of remarks from two of my roundtable colleagues, Melissa Simon. Dr. Simon is a clinical professor at Northwestern University, Feinberg School of Medicine, and Dr. Reggie Tucker Seeley, who is at the University of Southern California as a research scientist. And also we will have time for question and answer. So we encourage you as this webinar proceeds for you to use the question and answer option that you have on your Zoom box to pose a question to our panelists. Obviously, with so many participants, we won't be able to cover all questions, but we will certainly go through those and make sure that some of the more interesting and relevant questions be forwarded to our panelists. So with that, I think we're ready to start off with our panel discussion. I want to invite Dr. Brown to proceed on his first presentation, and he'll cover what we know about data collection challenges, and where we need to go with further evaluation. So Dr. Brown.
Thank you, Dr. Wong, and I want to thank the National Academies for the invitation to speak to you all today about COVID-19 and the spatial legacies of colonization and American apartheid. I want to start on the next slide with a story about Baltimore City, and it's important in terms of how we frame and collect data. In 1910, Baltimore became the first city in the United States to pass a racial zoning law. And what you see on the left of this slide is that the New York Times covered it. And they said that Baltimore tries drastic plan of race segregation. And in the middle of that article is Baltimore Mayor John Barry Mahul. So that was 1910. 7 years later, 1917, the man you see on the right, he became mayor, or he was the mayor, Mayor James Preston. And just like today, there was an outbreak of disease. This is before the 1918 flu pandemic. And this time, though, the disease was really ravaging a lot of African-American communities. And some of you may know that disease, tuberculosis. There were also other diseases that were prevalent at the time: cholera, yellow fever, infectious diseases of the day. And on the next slide, you'll see that basically in these newspaper articles, Baltimore used public health data in a very negative way. On the left, you see the New York Tribune, and they're using statistics. If you look at the bottom of the first paragraph, the heading, Negro Segregation Plan may be tried in Baltimore. And why is segregation, or why is segregation a part of the plan? If we look at the bottom of that article, it talks about the Negro death rate is 28 to 22,000, while the white death rate is 16 to 18. Basically, public health is being used as a rationale for intensifying racial segregation in Baltimore, which is the home of urban American apartheid. In the middle article from the Baltimore Sun, you see Mayor James Preston to aid 90,000 Negroes, which is what African Americans were called at the time, to aid them dealing with tuberculosis. He proposed a suburban colony. You can see on the third line. So on one hand, segregation in 1917 was posed as the solution, and on the other hand, pushing African Americans out of Baltimore City was posed as another solution. Segregation on one hand, forced displacement on the other hand, even though it was known at the time that housing conditions, living conditions were really the root of that pandemic, the root of tuberculosis spread at the time. Next slide. So how does that shape what we understand today about COVID-19? We see here, and we've all heard, that African Americans in particular, according to the data that we have, and like Dr. Wong said, we don't have all of the data, but the data that we do have that's being collected as of April 23rd shows that the African American death rate is more than twice the death rate of Asian, Latino, and white populations, more than double each of those three populations according to the data that we have so far. If we look below the total deaths, pretty much every other racial ethnic group is either on par with their percentage of the population or slightly below, as it is with the white population at only 47%. Whites are about maybe 60% of the United States population. But for African Americans, 28% of the deaths are African American, even though African Americans are only 13 to 14% of the United States population. And you see on the other side of the slide, the cities, the states in the United States where African Americans comprise a much greater share of deaths than it is proportionate to their populations. Next slide, please. Well, there was some argument. Did African Americans know? Were there myths going around? How much were they really concerned? Well, we have Pew Research data that actually said that if you look on the left side of the slide, where it's circled in red, African Americans, a higher percentage of African Americans, and this is of March 10th through the 16th. So early on in the pandemic, a greater percentage of African Americans had a major concern about COVID-19. Hispanic or Latinx population had the next highest concern, and then white in terms of major concern. And they're all roughly even in terms of having a major or minor concern. But we can see at that point early on, African Americans had the highest concern. If we look on the right side of that slide, we see racial differences and concerns over contracting COVID-19. And there we also see the Hispanic and Black populations having a higher concern that COVID-19 is going to impact them. And this was dated April 7th through April 12th. So it was not the case that Black people, according to the statistics, the survey, as we see here, that Black or Latinx folks were less concerned. In fact, whether you look in March or whether you look in April, Hispanic, Latinx, and African Americans have always been very concerned about this disease. Next slide, please. So nationally, there's a concern because we don't have data in all instances for everyone. Even the survey I just showed you doesn't have Native American represented in terms of how they thought about the virus. In many surveys, Asian Pacific Islanders, they're not captured. Even though there's a bill that's just passed, the Patient Protection Program and Healthcare Enhancement Act, that mandates data are collected. This bill does not state that there's data on LGBTQ populations, on individuals with disabilities. So there are gaps in our data. The data don't reflect everyone. But as I'm showing you earlier in starting off with this presentation, when we do have data, we have to be very careful because data can be used to stigmatize vulnerable populations, just like the way Baltimore used data to help increase racial segregation in that city. Next slide, please. So even though we're talking about data, I want to highlight that stories are also data and that stories matter. Here's Maya Pickering. She's a tribal member of the Oto Mississauria in Oklahoma, that tribe. And she recounts, if you look that up, you can hear her story about how COVID-19 testing for her was delayed about a week or so before she was able to get her first test to confirm the symptoms that she was having and that she indeed had COVID-19. And then, yes, you can go to the next slide. And then we also have heard stories that in the case of Gary Fowler, in the case of Deborah Gatewood, that people have been turned away from testing 3 and 4 times and have lost their lives due to the denial of testing in the healthcare system. Now, why might this be the case? Why might African Americans, Native Americans, and others be denied testing for so long? If we go to the next slide, what we see is that there can be racial testing in algorithms. And this article, Dissecting Racial Bias in an Algorithm, it shows us how racial bias actually can be used in algorithms. And the screening questions that were used at that point in time, I suggest, were a form of algorithm. They were used standardly across the nation. When I went to get my flu shot in March, I heard 2 questions. The first question, have you ever been, or have you been recently to Wuhan, China? No, I have not been. And there aren't a lot of Black people who've actually been to Wuhan, China. So that question may make them think, hey, I'm not that much at risk. And the other question was, do you have a fever? Or, are you coughing and that sort of thing? No, I wasn't. So that screening process, the questions that were asked, instead of understanding that there was the possibility of community spread and that the virus, if it's spreading in communities, that there are certain communities that are going to be more vulnerable, that question regimen, that screening question was an algorithm that actually turned a lot of people, or made a lot of people think, hey, I'm not vulnerable. And when in fact, they really, really were. And so next slide. I want to talk about how where testing happens matters. And so we see on the next slide that this was in late March in Shelby County, Tennessee. And what they found was that in the eastern portion of the county, there was a higher rate of COVID-19. Now, is that because there was actually more COVID-19 in that area? No. In fact, what was really happening is that the east side of the county, which is the wealthier side of the county, that is where the testing was taking place. In late March, there was not testing taking place in the more African-American, the less affluent part of the county in western Shelby County. And we also see something about the structure of the healthcare availability in the second map on the right. And we see there that in orange, yellow, and red, you have more healthcare facilities available. That helps explain why there was more testing on the east side of the county early on, but not on the west side of the county where many African Americans live. And if we can go to the next slide, after that information was released in a news story, you can see these blue dots representing testing sites that were now set up across the county. So now you have spatial equity more in place to help address why certain communities are to be able to actually test certain communities so that you can see and officials could obtain testing from multiple parts of the county and help determine where COVID-19 spread was really taking place. Next slide, please. So here's data from the New York Times. And basically what they showed in that orange line is that folks that were lower income after social or physical distancing went into place, they were still more mobile, still out and engaged in more movement compared to their wealthier counterparts. And I think we're going to talk about in a little bit why that might be the case, but it sort of could make sense if you have lower income folks that are more essential workers. They have to be out and about more, but it could also be a part of the communities in which they live. If you live in a community where you don't have a fresh grocery store or grocery store with fresh food. If you live in a community where your bank doesn't exist, so you have to travel further, that is part of the issue. Those are some of the issues we could see why a lot of folks that are lower income might have to travel more. And it's more due to the structure, the spatial structure of what's in their community and what's not in their community. Next slide, please. And so here are other cities, or here are cities where we can see that same pattern in San Francisco, Washington, D.C., New York City, Boston, Baltimore. Higher income people were able to stay home more. Lower income people had to travel further, had to be out of the home, and that is in part helping to explain the higher rate of COVID-19 in lower income populations. Next slide, please. And so let's look at the data. And I'm going to highlight how space is the place that, in fact, instead of talking solely about populations, what we really should be talking about is the spaces and places in which people live. Next slide. So there have been 3 waves of COVID-19. First, we saw in Seattle, California, nursing homes, cruise ships. That's where the first wave was. Then it really hit a lot of our larger cities, especially New York, the adjacent areas, and New Orleans. And now we're in the 3rd wave of the pandemic, rural areas, tribal lands, and the Deep South. And so a lot of these states, they're looking at opening earlier. Some of these states never engaged in a stay-at-home order. These governors, these states are at high risk because that is actually where we're seeing increases in COVID-19 right now. Next slide. So I didn't need a lot of population data to understand what was happening, because as soon as I heard New York, New Orleans, Detroit, Chicago, that those were the cities being hit, I understood as a social scientist, wait a minute, those are all hyper-segregated cities, or they have a legacy of hyper-segregation. And how do I know that? This is data from Douglas Massey, sociologist at Princeton, and his colleagues. And they talked about hyper-segregation in their article that you see below. And they classify segregation according to 5 measures: unevenness, isolation, clustering, concentration, and centralization. And if a city is only above 60, they all range from 0 to 60. And if a city is above 60 on one of those measures, then they're classified as low segregation. Above 60 on 2 of those, moderate segregation. If they're above 60 on 3 of those, then they're highly segregated. But if they're above 60 on 4 or 5 of those measures, they're classified as hyper-segregated. And so we see here, New York is a category 4. I like using the analogy of a hurricane. Category 4 hyper-segregated city. New Orleans used to be a hyper-segregated city. Now it's a highly segregated city, category 3. Detroit, category 5. Chicago, category 5. The cities that have been the most impacted are the cities that are hyper-segregated in this country. Next slide, please. And so here's some of that data. And this is data from our wonderful colleagues over at the University of Chicago, their US COVID-19 Atlas. We have all heard in the media a lot about New York City and the 5 boroughs. They have some variations. So this is the average from the resource that I use at the University of Chicago. 1,873 per 100,000. New Orleans, not too far behind. Albany, Georgia, 1,609. And then you see these other cities that you've heard about and some that you maybe have not heard about. But these cities all have a legacy of hyper-segregation, or they are still currently hyper-segregated. So this is telling us something this is telling us space is the place. It's not the people. It is the place in which they're living that is actually helping to explain why the rate of segregation is as high, or why the rate of COVID-19 is as high among certain populations. Next slide, please. So why segregation? Why is segregation so important? We see from the literature, damage that racial segregation causes is tremendous. It causes damage in terms of the resources that are available and the health outcomes that we see. Next slide, please. And so, no, you can go to the next slide as well. So here, I want to talk a little bit about in Native American communities, this model, historical trauma developed by Michelle Sotero, helps explain a lot about why we see more COVID-19 in certain Native American communities. Next slide. And so here in McKinley County, New Mexico, and Navajo County, Arizona, and Apache County, Arizona, we see high rates on par with Detroit, with Chicago, because again, the history of colonization in America, stripping resources from tribal lands, stripping land, power, culture from Native American communities. This is what's helping to explain the high rates of COVID-19 in tribal lands. And then finally, the last population or place I would like us to look at on the next slide is the correctional institutions. The counties that have certain correctional institutions, the ones you see listed here, have extremely high rates of COVID-19. This is astounding. And of course, what's happening inside correctional institutions can easily spread to the community because people work in and they go out. And so the nature of space and place in America, of apartheid and colonization, it helps to explain why we're seeing the outbreak in certain places at such high rates compared to other places. Next slide, please. And so I want to end with these solutions. If we're going to move forward as America, we first have to spatially contextualize COVID-19 data. It's not sufficient to just say people have a higher burden of disease. No, it's the places in which they live and the legacies of colonization and apartheid that's actually at the root of COVID-19, as these sort of factors are also at the root of many other diseases. Next, we have to decolonize and desegregate America. We have to get to the root of our inequality if we're going to address this virus. We have to pursue decarceration. Many prison populations are overcrowded, and we have a mass incarceration sort of system. We have to move away from that. And then finally, it is insane that we spend over $680 billion on the Department of Defense, but only $90 billion on the Department of Health and Human Services. We see the same type of practices at the city level, with Baltimore over $470 million on police, only less than $41 million on the Baltimore City Health Department. That is an apartheid budget. We cannot achieve healthy outcomes with apartheid systems, apartheid budgets, colonized spaces. We must actually decolonize and desegregate to actually defeat COVID-19 once and for all. Thank you. You're on mute, Dr. Wong.
Thank you, Dr. Brown. Very provocative questions and certainly a lot of food for thought. I do now want to transition to Dr. Gee, who's been at the forefront of Louisiana's crisis and has been doing a lot of work around testing. And I think through Dr. Gee's presentation, we'll get a better sense too of how data's facilitating how to test and how do we really understand the full dimensions of disparities and disproportionate burden impacting the African-American and other communities in Louisiana. So Dr. Gee.
Thank you for having me. So thank you also for the wonderful data that you presented, and all of what we are experiencing now is informed by our history and our history of racial segregation, our history of societal inequity, and all of that in addition to structural racism and implicit bias have led to where we are today. And this is a time to rebuild systems in a different way, to imagine them as different, not to build back what we had before, but to build something better. And I think if there is a silver lining for COVID, it is that opportunity, and the opportunity to understand the incredible challenges we face, but the things that we can do better on. Next slide. I think one thing that is first and foremost in my mind is that healthcare has to be an important part of this discussion. And I am extremely proud of the work that we did in Louisiana to extend access to healthcare for all people. We had an uninsurance rate of about a quarter of our adults in 2016 when Governor Edwards and I started. That rate is now 8%, which is below the national average. And certainly health insurance has improved access to care for communities of color as it has for everyone, but healthcare is a human right. And what you see here are the dashboard and a map of our state of not only the fact that people were able to get Medicaid coverage, but they got services, hundreds of thousands of people, breast cancer screening, cervical cancer screening, colon cancer, mental health and substance use. And this is all part of what we're dealing with. And frankly, I pity the states that did not have the type of leadership we've had and the governors that we've had. And most of these states are our neighbors, and they are much more vulnerable to COVID than other parts of our nation for some of the reasons we've already discussed, and the fact that the burden of chronic disease is higher in these deep South states, and they do not have an expansion. So just imagine, we didn't have to in Louisiana, but imagine there a COVID epidemic where your only access to care is an emergency room, and trying to manage that on top of everything else related to this epidemic. But I'll say that early on, and my training is as an obstetrician and gynecologist, but also health services researcher, and I made these dashboards to start demonstrating visually to policymakers. I had individuals who said, look, what difference does it make if we get people health care, if insurance, because no one will see them. Well, look, here you can see clearly they did have access to health care. And so part of this was a defense of healthcare coverage, but we also really started to look at data to demonstrate racial disparities. Next slide, please. And in our efforts that you've heard about to eliminate hepatitis C, we took the skill sets that we had honed with the creation of this first Medicaid expansion dashboard and really worked on targeting interventions to individuals who had hepatitis C, who were unable to receive treatment prior to our modified subscription model, which ensured that everyone in our departments of corrections who are disproportionately people of color and everybody in our Medicaid program could have access to a cure for which was then the most deadly infectious virus of our time. And we really looked at making sure that we did not take an all boats rise with the tide approach. We really looked at targeting healthcare disparities for hepatitis C and started measuring these disparities and talking about them. And next slide, please. And I'm very proud to say that this work has led to now what is a very veteran team's creation of a COVID dashboard. And we were the first state in the nation, at least as reported by the governor and in terms of my research, that has reported healthcare disparities by race as a state. Now, certainly there were counties that did this, but the whole state of Louisiana started reporting racial disparities data very early and started reporting it by parish, and is very committed to racial equity in our approach and looking at healthcare disparities from a data-driven perspective so that we can better understand this epidemic and how we can influence outcomes and ensure that we don't have disproportionate deaths. That being said, Louisiana was hit very hard by COVID. In the first 2 weeks of this epidemic, likely in large part due to Mardi Gras, we had the largest percentage growth, or 68% growth in the number of cases in the world at that time, even compared to Italy or New York City. So we had tremendous challenges in terms of large numbers of people who were exposed to a circulating virus before there was public communication about need for distancing and so on. And so we started off with quite a tremendous deficit, but I think our leadership on the data has paid off, frankly. And yesterday was the first time in 37 days we had not a single death here in Orleans Parish, a parish that is predominantly African American. And our rates statewide, initially it was 70% of deaths were individuals who were African American. Now that number is 59%, but our population here in Louisiana is 32. So still way out of proportion. The color of one's skin is an independent risk factor, I believe, for COVID. But it is that these types of data, reporting it and making sure that the public understands what these issues are, and having policy and public health experts who insist on showing data by race, reporting outcomes by race, I do think is a very important thing. A, so that the public understands what's going on, and B, so that policy solutions can be targeted directly to the communities in need, not a one-stop shop, solution for all. A great example of that is our testing strategy. Had a discussion yesterday with individuals at HHS and talking about, well, what needs to be done to improve access to testing. And I referenced an approach we've used in New Orleans. What we decided, instead of which was what was done initially, to have the federal government set up, places where people could drive and we would do drive-through testing, that we needed to go to communities. So we started last week in the Holly Grove area of New Orleans, which is a community of color, in large part about 70%, 75%, and also low income. And many individuals do not have cars. Many individuals were not able to get to areas where they were able to get tested. And it was very touching to me the first day we did testing, and we had an older lady who was over 90 walk a mile in the heat to get tested, and there were lines around the block. And so it just spoke to me. There are individuals who think, oh, we're fine on testing. Well, no, we're not, because we haven't tailored our approaches to our most vulnerable communities. It is individuals in those most vulnerable communities who are highest risk. And we really need to ask them and engage with them in a nothing about me without me approach. How do we tailor our testing to those communities? Because we know that unless we address, the risk of COVID and the ability to get tested in vulnerable communities, we will not be able to address this issue more broad scale, and we will have and continue to have disparate outcomes. So I think approaches like what we have done at LSU in partnership with LCMC and the City of New Orleans are promising ones, but much, much more needs to be done. Next slide. So one of the things that I'm very proud of is that under Governor Edwards' leadership, when I was Secretary of Health, we established the first Office of Community Partnerships and Health Equity, or any office that says health equity in the state of Louisiana. And this office, I think, is what we are building on now with the next initiative that I'll discuss that the governor announced last week. But what this was an effort to, first and foremost, change the culture of the department, really look at the individuals who are in leadership. We required that every senior leader at our institution evaluate their own perceptions about race and do an undoing racism training, that they be reflective on how their thoughts and attitudes and personal experience and history would influence how they make decisions, and about individuals who are not like them, or individuals who are other, whether those are individuals who have disabilities, or if it's somebody who comes from a different background or community than you. If you're making decisions on their behalf, you really need to examine your own implicit bias. And so I think this was extremely important work, and we had very multiple honest conversations among senior leaders about how we would address this going forward. And I do believe, and we also created what we call HEAT teams, or health equity action teams, in every facet of the health department. So this was not just a health equity plan. It was the fact that health equity became part and parcel of every decision that we made. And when we made decisions, that the health equity action team would be a part of those decisions and make sure that we were in a nothing about me without me mantra, to quote Don Berwick, really considering the communities we serve before we make decisions on their behalf. And I do believe it was this cultural change that has paid off with COVID, where at the very least, the health department has been proactive in showing rates by race and addressing communities of color separately in terms of what the needs might be to solve the problem. And our governor acknowledging the fact that health equity is a priority and understanding some of the foundations on which health inequities are built. I think all of that was very important, and I would encourage other health departments to create, or state agencies to create offices of health equity and consider HEAT teams or other really active partnerships in decision making, because you can talk all day about health equity, but if you don't have individuals who are part of a decision making team who are really focused on health equity, you will not be able to address it in your policy. So again, I think a very important initiative. Next slide, please. So on April 24th, the governor announced the Health Equity Task Force, which I'm serving on for the state. I believe that there are 1 or 2 other states that have, Michigan maybe, that have similar approaches, but we're really excited about this work. It comes with $500,000 of funding. Some of the things that I think are very important to address early on are testing in vulnerable communities, making sure that we don't rely on coming to us, that we come to them. And we've got to ensure that individuals who are essential workers, who are disproportionately women, or 52% of them are women, and disproportionately minorities, are able to have access to resources. So we can't ask people to have to sequester themselves if they're COVID positive and be separated from family and not able to work if there aren't income protections for them, if there aren't places for them to go. Low-income communities are more likely to have smaller homes where multi-generations are living together, and all of this needs to be considered in a COVID response. We need funding to ensure that people can have the time to recover from COVID and do that in a safe way. We also need to make sure that we're protecting our essential workers. We treat our essential workers as if they're disposable. We've long delayed on national guidelines that suggest what are, based on material science and virology, the right types of protection for individuals who are frontline, who are essential but may not be healthcare workers. And these individuals are disproportionately low-income hourly workers, many of whom don't have paid sick leave and other policies that allow them to have the assurance that if they get sick, they will be able to be cared for and care for their families. And so these are all important policies that need to be addressed in response. And then I think finally, COVID's teaching us that childcare is not just a women's issue. Childcare is important for society to function, and we have disproportionate in Louisiana number of families are single parent, and when the single parent's working, the older generation is caring for children, and this is exactly not the scenario that we want to see during COVID. We want to see individuals who have comorbidities or pre-existing conditions that make them more vulnerable to COVID, being able to not be around children and those who are high risk. But this is unfortunately not the luxury that many people are able to have. So all of these policies are very important in thinking through what we're going to do to get on the other side of this epidemic and build a better world. And I would love to hear from others on this call your thoughts about how the task force should address racial disparities and what systems should we build back, whether it's paid family leave, whether it's making sure that individuals have places to recover, whether it's making sure that we have a test for everyone that's delivered directly to communities, whether it's free healthcare, which is what we've been able to provide through our through an app this month with LSU and K Health, so that individuals who are uninsured or underinsured can have access to a physician and ask questions. I think all of these need to be entertained and more, but clearly we know that the healthcare system that we have is not optimally built to address healthcare disparities, and it must be improved. Next slide.
And Dr. Gee, we have about 2 more minutes for your, or about 3 more minutes for your presentation.
Yeah, and this is my last slide. This is Ellis Marcellus, and I wanted to focus on, just for a minute, the faces of individuals and their stories who we've lost. I mean, look, he was really the dean of our Jazz Congress. He was a professor, a teacher, an artist. He represents so much of New Orleans culture and what we take pride in, and we lost him to COVID. And so we can't delay any longer. Every single life lost is a life lost. It's a tragedy, and we can't lose sight of that as we address this epidemic and lose our sense of urgency over, all of the failures we have and what needs to be done. We need to massively mobilize testing. We need to massively mobilize contact tracing. We need to do all of these things in partnership with communities so that the solutions that we develop don't ignore the realities that people face and and the hardships that they're encountering throughout this epidemic. So I'll stop there and thank you for having me.
Great, Dr. Guillen. Thank you for your service to Louisiana and to the nation and making these points in practice. So next we'll go to Dr. Stephen Thomas, and we are monitoring the questions as they're being brought forward by our audience. We know there are still lingering questions with regards to testing and where we decide to do testing. We also know that there are questions with regards to why is there variability with regards to which states and which jurisdictions report disaggregated data for race and other components. So we do want our panelists to consider those questions, not only in your presentation, but as we queue up the discussion period. So Dr. Thomas.
Well, thank you very much. What an amazing set of talks and what an audience that's out there. I've got a tough job bringing up the tail end here. And in my screen, I want you to see I'm starting with, from my perspective, what I think are the solutions. These are examples of how our team here at the University of Maryland College Park has translated the science of medicine and public health into culturally tailored community-based interventions. And it is these tailored interventions, long-term commitment to community engagement that I think is indeed the solution to the problems that we face today. In many ways, the problems that COVID-19 has exposed. And I've asked myself this question, after all that this virus has exposed, the deferred maintenance of our public health infrastructure, the challenge of not only collecting the data, but that when we collect it and interpret it, how it can be used in ways that may be unintended. I said to myself, where do we go from here? And so I think that building bridges, building trust is our key to building healthy communities, and the recognition of the underlying health conditions that are associated with very, very negative outcomes for COVID-19 infection, the cardiovascular disease, the hypertension, the asthma. These are all conditions that were festering before COVID-19. And let us hope that in our zeal to return to some sense of normalcy, that we actually look at this data that's being presented today, we look at the fissures in our society that it's exposing, and commit ourselves to returning to something better than we had, something better than we had. And the lower left corner, you'll see where it says Mission of Mercy, where we would literally take our basketball arena and turn it into an emergency dental clinic. We'd have thousands of people lining up to get free dental care. Thousands of people. Think about this, ladies and gentlemen. We're 9 miles from the White House, one of the wealthiest countries in the world, the wealthiest county in the world. Thousands of people lining up for free dental care. And the vast majority of them had some form of insurance that unfortunately didn't cover anything of value, or else they wouldn't be sleeping outside overnight for free dental care. They came through those doors with all of the comorbidities that we're now talking about in the context of COVID-19. So I think it's very important for us to recognize that whatever we build on the other side of this pandemic must be better than what we had before. Coming around that, the slide set, you'll see also something that says Barbershop Health Initiative. And so it's very curious to me to see that we have a challenge of barbershops in Georgia literally going out and opening up. I don't know of any self-respecting barber who can give you a haircut 6 feet away. And then you see our health equity initiative. And in Maryland, we have a health and all policy campaign that was our policy response to addressing these social inequalities. Next slide. And I'm just going to let you come to me because I'm going to talk to this audience here. wanted to comment on what Dr. Brown said about what was happening in 1910. You can take the slide down and I'll just talk to the audience. The 1910 segregation in Baltimore, the 1970 TB outbreak, 1917, the use of data to discriminate. In between that time was 1915 when Booker T. Washington launched the National Negro Health Movement. In other words, he recognized these health disparities back in his day. But racial segregation, the history of slavery prevented modern public health from serving the needs of these rural communities in Alabama. And so he brought together community organizations, churches, civic groups, and launched the National Negro Health Movement. In the 1930s, it became the first federal office of Negro Health Works. And that is the mother of all of these offices of minority health that we talk about today. And so it's Booker T. Washington's frame that I want to share with you, because he said that if there is no struggle, there is no progress. But those who profess freedom and yet depreciate agitation are men who want crops without plowing the ground. They want rain without thunder and lightning. They want the ocean without the awful roar of its many waters. What we're seeing today in this data should make us, it has made me it has sobered me to the pain and suffering that's out there. And it has angered me to the fact that we know more now than we've ever known about how to prevent many of these underlying chronic conditions, and yet we have not implemented what's necessary to address them. COVID-19 now places that front and center, that we must use the data not simply to target our communities, but to prioritize them. So as long as the data is being used to prioritize where the resources need to go, I'm all for that. But we have yet to prove that that is in fact the case. And I think that this audience must ensure the oversight necessary that the resources follow the data. And the words we use are also important. While there may be some difference in style, whether we call it a health equity or health inequality, these words convey value and beliefs. And we're stuck with social distancing, unfortunately, when we're really talking about physical distancing, but it has resulted in some confusion in some of our communities that are at greatest risk based on the prevalence of the disease, meaning that they are socially distant from strangers, but when it comes to family members and people they know, they want to gather and unfortunately place one another at risk. So when we're talking about health equity, it means that everyone has a fair and just opportunity to be as healthy as possible. And for the purpose of measurement, health equity means reducing and ultimately eliminating disparities in health and its determinants that adversely affect excluded or marginalized populations. That's the key, excluded or marginalized populations. So if an effort does not address poverty, does not address discrimination, or their health damaging consequences for groups of people who have historically been excluded or marginalized, it is probably not a health equity effort. So to put all of your COVID-19 test sites and contact tracing sites in the wealthiest parts of the communities, don't call that health equity. Health equity means we're addressing the needs of our most vulnerable populations. And for some of those groups, there is a history. Dr. Brown described some of that history, a history of the burdens of race and poverty, and a history of health professionals coming in the name of science and actually resulting in research abuse. And here's an area where, again, we need good data on who's participating in COVID-19 clinical trials. We need an opportunity for our communities to participate, but recognize that the resistance, the fear that one may encounter is legitimate. That a history of research abuse from the Tuskegee syphilis study to other examples still lives alive and well in many of our communities. It's part of the oral tradition. It's part of the wisdom passed from one generation to the next. And we have to recognize that as COVID-19 continues to ravage these neighborhoods, a disease right now where there are no good treatments and no vaccine. And you have to ask yourself, if a vaccine was available tomorrow, who would take it? With the very communities that we're talking about now suffering these burdens of disproportionate negative outcomes, would they take it? I think we need to prepare now to increase the likelihood that they have the opportunity to be part of clinical trials. And so we're early in this process. I think that we are really in the first inning. We have a difficult time explaining to the American people what this is and why it's so important. And so comparisons to the flu kind of lose meaning when you realize that no human being on the planet has been exposed to COVID-19. And as a result, we have a pandemic on our hands. And that's something that people are experiencing for the first time. We have to go back all the way to 1918 for lessons. And I think there are lessons there, lessons that include how were Black health professionals treated back in 1918? How were African Americans treated back then during a time of Jim Crow? All of these legacies of race are part of what we are now addressing today. They're part of the deferred maintenance on issues of race and disparities in our nation. COVID-19 provides an opportunity for us to address those issues. And I'm hoping that in our conversation that we're going to have, we can open up a discussion about how to ensure that where we go next is not where we've been. I want to acknowledge in my background, you see a picture of my mother who's a nurse. And if she were here, she'd be on those front lines. And I want to really lift up and say that we also need data on healthcare professionals who have been also significantly impacted by this disease, both potentially risking their own health, risking the health of their families, and the tremendous mental and anguish and anxiety that they're experiencing. And even among our, just yesterday, the announcement that Dr. Bayless Walker passed away from COVID-19. And there are other very prominent members of our communities and not so prominent members of our communities that have died. I think it's very important that we put a heartbeat on the data statistics that you've heard today, and not simply, as we have, in my opinion, with the chronic diseases, accept them as that's the way it is. Racially segregated concentrations of chronic disease we've been living with, but I cannot shake your hand and give you type 2 diabetes. That's not the case with COVID-19. Wherever this virus lives and spreads, it will not be contained. That's the lesson here. And so here is our chance with tremendous resources being pumped into this area to, for once and for all, address the underlying social inequalities, the structural racism, institutional bias that has been fueling the racial and ethnic health disparities that we've lived with so far. And so with that, I'll turn the table over to Dr. Wong and thank my fellow presenters for teeing this up for me, and look forward to the conversation that we'll have with our audience.
Well, thank you, Dr. Thomas. Some very important messages. And we are monitoring the questions. There's so many questions to take on with this topic, which would probably take the whole day. But before we turn to our Q&A, I did want to invite two of our roundtable members to offer some perspectives. It would be relatively short, a minute or two. Our first roundtable member is Dr. Reginald Tucker Seeley.
Great, thanks, Winston. So as Winston mentioned, I'm Reggie Tucker Seeley. I'm the Edward Snyder Assistant Professor of Gerontology at the Leonard Davis School of Gerontology at the University of Southern California. I want to first thank the presenters for their presentation and helping us to explore the data needs related to the COVID-19 pandemic. I think the fundamental causes theory helps us to explain what many of us health disparities researchers are really not surprised by, in how this pandemic is disproportionately impacting racial and ethnic minorities, low-income individuals, older adults, and among populations within institutions such as nursing homes and correctional facilities. And I think this framework can also help us to explain to the many who seem very surprised by this disproportionate impact. So this theory suggests that resources such as money, knowledge, prestige, power, and beneficial social connections are sorted by socioeconomic position. And these resources create the social context where health behaviors are implemented and our health status is produced. And in creating this context, the resources or lack of such resources are the factors that put people at risk of risk. And if we think about the factors that put people at risk of risk, this helps us to understand how socioeconomic status structures the patterns of social circumstances and the resources available to populations to protect their health. We know that socioeconomic resources are disproportionately sorted by race ethnicity, with Black and Brown and Native households having substantially fewer financial resources compared to other racial and ethnic groups. And in addition, as Dr. Brown mentioned, space is the place. And the hard-hit cities are hyper-segregated, where this segregation has sorted racial and ethnic minorities into neighborhoods with fewer resources and increased risks for negative health outcomes. I was glad to hear that Dr. G mentioned that they didn't take a rising tide lifts all boats approach in Louisiana. I've heard that phrase in policy discussions as justifications against more targeted approaches, but we must recognize that not all boats are prepared for that rising tide. And I recognize that it can be quite challenging to implement policies that not only make improvements in the overall population, but also targeting populations that have historically been the targets of neighborhood segregation and racism. But this is a challenge we must meet. It's also important to think about the disparities during this pandemic are not only in the final outcomes, such as mortality, but from the processes of what puts people at risk for exposure to COVID-19, the differential access to testing, the different levels of access to healthcare, and differences in navigation of healthcare and treatment in healthcare, differences in caregiving responsibilities, and differences in the financial resources to navigate and manage healthcare and caregiving. Lastly, I was glad to hear Dr. Thomas discuss the importance of defining and measuring health disparities and health equity. I think there is an underappreciation for the challenge in moving through the process of defining, measuring, reporting, and intervening on health disparities. In particular, first, if we don't have the data for specific racial and ethnic groups or other sociodemographic categories, we can't calculate differences between those groups. But even once we have the data, when is a difference a disparity? And next, when is a difference actionable? And as we know, and many of us have experienced, any shortcuts taken in the definition, measuring, and reporting process can greatly impact intervention and policy efforts focused on reducing health disparities. Thank you.
Thank you, Dr. Tucker-Seeley. And I invite Dr. Simon, who's also on our roundtable, to offer some remarks.
Hi, thank you. Just real quickly, for time's sake, again, we have to understand historical context of decades of legacy of racism and structural racism causing all of the other downstream effects, disinvestment in communities and hypersegregation, et cetera. Data are important. It's important to remember that data can be used in positive ways and data can be used in very negative ways. And we have to be very mindful of that and how we use data to create real solutions are really important. We have to be creative in having the infrastructure from other existing programs. So Louisiana's dashboard was a really good example of being able to have existing structures that can be mobilized and used for COVID and other emergency responses. And then also it's important to understand the whole arc. If we're gonna ask for widespread testing and get testing to communities, we have to remember the whole other stuff that comes with testing, like where are you going to quarantine people, what are you going to do, how are you going to get vaccines to them, treatments to them, and all of that needs to be looked at in a holistic way and not just say we need tests. And then COVID is teaching us that care in general, child care, adult care, elder care, et cetera, are important for society to function. And so we always have to think about that, how we care for our homeless, how we care for people in prison or in juvenile detention centers and on reservations and all over the different geographies of our country. And then I just really loved with what was said by our speakers in terms of clearly the healthcare system that we have is not optimal to address the disparities at hand. And whatever we build on the other side of this pandemic must be better than before. Thanks.
Thank you, Dr. Simon. So now we're going to go into our Q&A, and thank you for our panelists. One of the issues that recurs with regards to the questions that are being brought forward to us by our audience, as well as kind of a lingering question, is the denominator, i.e. testing across our communities is severely lacking, and dare say disproportionately lack of testing in vulnerable communities. I was wondering if you could comment around if we were to design the best situation to get the best data with regards to creating the denominator for testing, what would that look like, and how would you change what is currently occurring? And for us to look at the raw data with some sort of nuance in terms of understanding the dimension of the infection and the pandemic. I wonder if any of you can comment on that.
Well, I think the main thing I'll say is that, I think I go back to spatial equity. I think and spatial equity is racial equity because racism in America operates at a spatial level as well. So I think that we have to understand in all of our cities where there are vulnerable populations, we should actually be doing more testing in those communities, in those incarcerated facilities, so that we can identify. That is the purpose of testing. I think some people mentioned in the questions whether or not it made sense to break down by race and ethnicity. Yes, it does make sense because there's a history of disproportionate treatment. Therefore, we need a breakdown so that we can identify if, in fact, people are still being treated disproportionately in a negative way. And I think the same thing is true, not just for people, but for neighborhoods. So I think we have to actually make sure there's a flood of resources, emergency response, community health workers with PPE, testing. There should be a disproportionate, in a positive way, mobilization for the emergency response to COVID-19 and in the recovery.
Dr. Wong, may I comment?
Yes, please, Dr. Thomas.
I'll just say what Dr. Brown just said is the difference between using the data to be a target and a hotspot and a place businesses don't want to come to, and a place businesses say, hey, those workers are going to drive my health insurance high because they have a lot of chronic disease. That's where we were, to what he's describing now, which is the data being used as a priority. Prioritizing those neighborhoods and addressing the structural, I call it deferred maintenance that has happened in those communities. That is our ticket back to a better world than the one we left.
Thank you, Dr. Thomas. Dr. Gee, there's been a couple of questions that have come forward with regards to your experience, with regards to how we address issues around disabled communities and also nursing home facilities, which have been an important part of what we've seen in terms of disproportionate burden. Can you comment about what we need to do with regards to gathering more robust data for those populations in nursing home facilities and disabled individuals?
Sure. I just want to start by saying I think it's unacceptable that we don't have requirements for reporting, particularly deaths by race, ethnicity. It's, we use death certificates. This is easily done by any state, and why this isn't happening everywhere, I just don't know. In terms of testing, it's harder to report the data, because we don't always collect race ethnicity data when we're conducting testing, but we are doing that in Louisiana. Some of it's from medical records, and we're certainly at least trying and doing our best. Because, as you said, I loved this saying that racial equity is spatial equity. We're really trying to address communities where we're seeing people come in and they're sick, and we realize that that zip code that they're coming from is not having appropriate testing. We've got to be reflective and target interventions to communities where we know the resources are lacking. And so on nursing homes, look, we ended our wait list for individuals with disabilities in Governor Edwards' first term. That's something that I'm very proud of, because a wait list is not a service, as the community would say. And so really focused on making sure people can get services they need in the home. But if individuals need a nursing home, look, I think we can all see the failures. I mean, we had a veterans home here in Louisiana, 5 people died. So clearly we need to do better. We need to have protocols. We need to make sure to be able to appropriately isolate individuals who have COVID from others, and be able to test every single person in every single long-term care facility multiple times, so that we can appropriately address this epidemic. We need appropriate contact tracing. Arguably, that's just not happening. It certainly is not happening to the extent it needs to happen. So yes, I think we need to be very concerned about individuals with disabilities. And I like to think about these issues, not just from the standpoint of the color of one's skin, but also, are you just not able to access healthcare for any kind of reason? Or is it whether it's structural racism or the fact that you have a disability? We need to be concerned about everyone during this epidemic, and make sure that we consider carefully all of the barriers to care, and that we address those specifically in our policies, not in an all boats rise, but in the targeted interventions to address vulnerable communities. And unless we do that, we will not be successful.
Great. Dr. Brown, since you deal with the county health rankings, I imagine your entire professional life is around trying to aggregate data that's meaningful. With regards to the COVID-19, it's distressing that we actually don't have any uniform way of reporting the data for different aspects of disaggregation, race, and otherwise. Why is that so? Is it more an organizational, or is it a political thing where certain leaders don't want to report disaggregated data? Are there methodological issues that we need to just take one sweeping mandate and apply? Can you comment about some of those issues?
Sure. I think we have to consider that America, in fact, has a third world public health system. I think we like to pride ourselves on being advanced, on being a developed country. I think we've been exposed by this virus, particularly our public health system. And I think that we don't track what we don't want to know as a nation. If we wanted to know, we would track it. We have trillions of dollars that we could have spent beforehand to develop a world-class public health system. We didn't do that. We could have spent billions of dollars creating a world-class data collection system to track race, gender orientation, to all the populations, disability that have experienced marginalization and demonization in this country's history. We didn't do that. So this was a political choice that we've made. We put our heads in the sand like ostriches, and we thought that something like this wouldn't happen. So I think we've been exposed. And when I say we, I mean the public health community as a part of that. We as researchers, we as public health professionals, some of us are on this call. We have to track these things. If we are in these systems, we have to make sure these systems are collecting the information that we need before the pandemic. Don't wait till the pandemic. The reason why we don't have it now is because those systems weren't set up beforehand.
Another arena that's been emerging is looking towards some new approaches to gathering data, namely using cell phone data and other technologies. So for example, some people are proposing that as we go into the next stage of COVID-19 containment, that we would use apps on our phone to kind of monitor where we are, et cetera. Can you comment about whether that is something you would be intrigued by or worried about relative to implications that we touched upon here in terms of discrimination. On the other hand, trying to find different ways of gathering data that represents spatial and community trends with regards to inequity.
So
I am intrigued by it. I think there are opportunities for it, but I encourage people to read Dr. Ruha Benjamin's book, Race After Technology. And she talks about the new Jim Code, that the way that we develop technology and apps and mobile apps and software. Sophia Nobles has a book, Algorithms of Oppression. Both of these books and texts talk about how if we're not careful, like the racial bias I mentioned in my presentation, racism will be encoded and deepened and in fact accelerated in our technological advances, such as tracking this disease with apps and software and things like that. So I think we have to be very careful. And I'm sure our other guests can speak to that, my other colleagues.
So if I'd like to speak to it. Interesting enough, I discovered the limitations of the technology recently. My iPhone will open based on facial recognition, or else I have to put in my long code. And now because I live in the state of Maryland and I'm required by regulation, I could be fined if I break the regulation. When I'm out in public, I have to wear a mask. And this is my mask. And you've probably seen in the paper, again, unintended consequences, where particularly African-American men feeling that putting that mask on makes them a target, not a sign of someone helping. But the mother of one of my students made this one for me, and I'm convinced that anybody in a cow mask cannot be a thug. So maybe you'll be embraced. The point here is that, and I'll use the Surgeon General's example, Big Mama and Pap Pap have flip phones. They don't have smartphones. They got throwaway phones. They live in neighborhoods that are internet deserts. So if anything COVID-19 has exposed, it is that we cannot have spaces locked away of the internet. It is vital. We are privileged to be working from home, those of us who have high-speed internet. Millions of people do not have that. We cannot create a world on the other side of this pandemic where we allow swaths of our country to be completely cut off from the internet. That must be a priority. And Dr. Brown, you're absolutely right. Who's at the table when we're writing the code? I see a lot of the companies. I do not see diversity in the companies, and that's no guarantee. But one guarantee is what we're doing right here. We're saying that data on race and ethnicity are vitally important. It has to be out front. And we're not going to count just for counting's sake. We're going to count to take action.
That's a great note for us to wind up the webinar. One of the real take-home points is about how data should prioritize as opposed to stigmatize, and how we think about this spatially, and a correlation between hyper-segregation and what we see in terms of the disproportionate burden, as well as fully acknowledging that we have still an incomplete story with regards to the full dimensions of the pandemic. I want to thank all our panelists who took time away from their very busy schedules, and certainly the staff and supporters at the National Academy of Sciences, specifically Karen Anderson, Rose Martinez, and Alexis, and my colleagues on the roundtable, many who could not have made it today, but you heard from a couple of them, Dr. Simon and Dr. Tucker. As a reminder, this webinar has been recorded and will be posted on the Roundtable's website for the next 75 days. So if you want to share with others or recapture some of the moments, that's available. With that, I just would ask any of our speakers if you want to have 10 or 15 seconds for your takeaway message, and then we'll sign off.
Well,
Dr. Thomas first, go ahead.
I'll just say
15 seconds.
15 seconds, support our healthcare professionals, but also the guy in the loading dock, the person who's bagging your groceries, and recognize that we need a lot of empathy right now. We need a lot of tolerance towards one another right now. And I hope that that's the other message of this pandemic.
Dr. Brown?
Yes, I'll say we should also mention the Asian American community that has also been stigmatized and marginalized by the characterizations of this disease. And there's research that shows that white people that live in red line communities, their health is also harmed too. So everybody is impacted one way or the other.
Thank you. Dr. Gee?
We need to demand that as we come up with solutions, whether it's funding for COVID or other policy solutions, that they involve communities of color, they involve communities who have alternative perspectives or may not be considered by mainstream. We've got to do that and ensure representation, and also make sure that we don't, I'm very worried about our history in this country of immunoprivilege, and making sure that as we start to recover and we're on a very long journey, we don't, disadvantage individuals who have not had this disease or don't have access to antibody tests. So just really a push that we've got to think about all of this now in our policies. We're nowhere near the end of this epidemic, and we've got a lot of work to do, but we need to insist on requiring showing data, requiring addressing this data in very targeted ways. And thank you so much for having me today.
Thank you all. And as a reminder, this is first of hopefully a few additional webinars that the Roundtable on Health Equity will be putting together to address issues of concern around COVID-19. Thank you very much, and be safe, and think of our loved ones and think of the people we lost. Thank you.